a new area. Some of you may be familiar with it. Some of you may have not have heard about this before, and it is in the LEA closure session, and it's saying let's open instead of close. So a little bit different than what we've been talking about so far, but an exciting space. So one of the common denominators, whether it's diastolic heart failure or systolic heart failure, is elevated left atrial pressure. And when the pressure in the left atrium goes up, it creates pulmonary venous congestion, and patients feel dyspneic. We know that left atrial pressure, or its surrogate pulmonary capillary wedge pressure, has prognostic value. When it's elevated, patients can exercise less, they don't live as long, and elevations in left atrial pressure precede hospitalizations and can be modified by certain medications. All that being said, the therapies that we use to address left atrial pressure elevations, particularly in diastolic heart failure, don't seem to have a mortality benefit. The way that we address left atrial pressure in systolic heart failure, it's by moderating afterload or preload or doing something with left ventricular contractility. There really are no left atrial pressure elevation dedicated kind of therapies. So what if we created a therapy designed specifically to address elevations in left atrial pressure? And it might look something like this. As left atrial pressure goes up, might you put a shunt into the atrial septum to alleviate the pressure in the left atrium and offload it to the right atrium? And this strategy is currently being evaluated by a handful of devices. I've listed them here on the right. The Corvia interatrial shunt device is the furthest along in clinical trials. Second place, I would say, is the V-Wave device, just entered clinical trials in the fall. And then there's an atrial flow regulator device. This has primarily been used in pediatrics and pulmonary hypertension, but the fundamental pathophysiology and intent is the same. And before you say it might be crazy to create an ASD when we're closing PFOs to prevent stroke and closing ASDs in the setting of RV dilation, there is a precedent for this. So observational studies from the early 1900s suggested that patients with left-sided heart disease, usually mitral stenosis, and a coincident ASD did pretty well. In fact, in the case study I have here pasted on the left side of the slide, there was a female that lived to 70 with severe mitral stenosis and gave birth to 12 children. With a mitral stenosis that was severe and an ASD. We also know that there are cases when an ASD is closed in the cath lab and you search shortly thereafter notice marked elevations in left atrial pressure. And then, of course, the case series about atrial septostomies for patients with refractory heart failure and hypoxemia. So let's review the early clinical data. As I mentioned, the Corvia device is furthest along in clinical trials. This is the list of the things that have been accomplished. I'm going to focus on the two in the middle because they have at least 12-month follow-up. The randomized trial that they performed was 44 patients, and it was an exercise right heart cath to get into the trial. And their primary outcome was an exercise right heart cath, looking at how pulmonary capillary wedge pressure changed during exercise. And as you can appreciate, the blue lines are lower than the yellow. Patients that received the device had lower pulmonary capillary wedge pressure with exercise. When you follow those patients out to a year, what you appreciate is, yeah, they can exercise longer if they have the shunt. NYHA class improves. They can walk longer. And the shunt fraction was relatively stable. It was 1.3 to 1, depending on what time you look at, and it didn't decrease or increase over time. This is 12-month data. When you look at the aggregate of the trials and experience published with that device to date, you'll recognize pretty quickly that it appears to be safe. Survival at a year is very high. Freedom from stroke is 99%. And patency of the device so far has been 100%. It also appears to have efficacy. So most patients, again, improve functional class of heart failure. The freedom from heart failure hospitalizations, which was a benchmark for enrollment in one of these, was 80% at 1 year. And again, patency is established. This is the current enrolling trial. It's called Reduce LAP HF2. This is a large trial, about over 600 patients. It's enrolling now, and it has a primary endpoint of mortality, ischemic stroke at 12 months, and it also includes the rate of heart failure hospitalization. So when this is completed, we may actually have a brand new device to treat heart failure, diastolic heart failure, within that trial anyways. This is the V-Wave device. The trials with the V-Wave device have been a little different. The first-in-man experience was actually in NYHA 3 and 4 patients that really didn't have another option. So end-stage heart failure patients Dr. Rodis Cabot in Canada implanted these patients. The implants were successful. The survival at 3 months was 9 out of 10, and they noticed favorable hemodynamics in that early experience. The issue with the initial issue with the V-Wave device is when they went back and looked at these patients at 3 and 6 months, they realized that a number of them had either reduced flow across the device or the absence of flow. And that was related to the valve. So with the first generation of this V-Wave device had a valve that only allowed left to right atrial flow. What they observed is that valve likely supported pannus infiltration and a lack of shut patency in 1 out of 3 patients. That being said, the second generation device has no valve and is currently in clinical trials for them. I'll share with you one final thing here. This is the V-Wave experience. What they did is they took patients that had a patent device at follow-up versus those that didn't. And if you look at the green lines, those are that have the patent device, and hemodynamics were favorably affected. That is, wedge pressure decreased, the gradient between the left and right atrial pressure was maintained, and then I mentioned the functional and hemodynamic effects on the last slide. So in the spirit of time, I'm going to conclude there. Interatrial shunts represent the first therapies that may directly affect left atrial pressure. We need a lot more experience in these. Usually a hand shoots up and says, hey, aren't you guys usually closing these holes? What about RV dilation? What about paradoxical embolus? So it's going to be the kind of thing that requires a few years of follow-up before we really know what the consequences of the procedure itself are. But early data suggests it's safe, suggests it's effective, and it's an exciting time to be an interventional cardiologist and friends with a heart failure doc. So thank you very much.
Thank you.